Hello, Clinic Review family. It's so good to see you again. Today we are going to be doing pre-op, and it's not the kind of thing that really lends itself to teaching the content. So we're just going to do some questions that you could see on the Nclex related to pre-op, particularly teaching and the medications that we may have to give pre-op and signing of consents and so forth. So that's the kind of thing, questions we're going to be going over today. Thank you to all of our channel members. I really appreciate it. If you're interested in paying me for something, since our YouTube channel is free, if you're interested in paying me for something, you can go to clinicreviews.com, sign up for the next gen small group tutoring with me. And Mark Klimek also does small group tutoring. You can sign up with him for that. If you go to the website, it'll describe what he does. I'm the only one that does the next gen. He does other things. So let's go ahead and get started with the questions right now. All right, the client has a latex allergy. What should the nurse teach the client to do before having surgery? Select all that apply. Determine that there will be a latex safe environment for surgery. Report symptoms experienced with the latex allergy, for example, rhinitis, conjunctivitis, and flushing. Notify the healthcare providers at the surgery center. Wear a stainless steel medical alert bracelet into the surgical suite. Ask to have the surgery at a hospital or take diphenhydramine pre-op to prevent any allergic response to latex. So with SATA questions, I like to read the question, read the answers, read the questions again, kind of shows me where this question is going. So the client has a latex allergy. What should the nurse teach the client to do? So I think that's the critical thing we're teaching the client to do. So let me turn this into a series of true false statements. I would teach the client to determine if there will be latex, it will be have a latex safe environment for surgery. No, I don't tell the client to do that because that's not the client's responsibility. That's the hospital or surgery center's responsibility. I would tell the client to report symptoms experienced with the latex allergy. Yes, I would definitely tell the client to report symptoms that they experience with latex allergy. So B is true. I would tell the client to notify the healthcare providers at the surgery center. Absolutely, I would tell them to do that. So C is true. I would tell the client to wear stainless steel medical alert bracelet into the surgical suite. Yes, I would tell them to do that. So they can wear stainless steel medical alert bracelet. So that is true that they can do that. I would tell the client to ask to have the surgery at a hospital. No, having it at the hospital doesn't decrease their risk for latex. I would tell the client to take diphenhydramine pre-op to prevent any allergic response to latex. So I don't tell them to take an over-the-counter medicine for this, especially pre-op. They're going to be NPO. I'm not telling them to take something over the counter. So I would tell them to do those three things. And the key word there is, what would I tell the client to do before having surgery? All right, next question. When the nurse asks the client who's having abdominal surgery today, if the client understands the procedure, the client replies, no, not really. I talked about several different things with my surgeon. I'm just not sure. What should the nurse do next? Teach the client all the details of the planned procedure. Utilize a second witness when the client signs for consent. Notify the surgeon of the client's express lack of understanding, or administer the prescribed pre-op narcotics and or sedatives. So the question says, I don't really understand what's going on. So what am I going to do? Because what I do is I go, and this is true on the test, it's true in real life. You go in with the consent, the nurse gets the consent signed. The nurse goes in and says, did the doctor or the anesthesiologist or whoever explain the procedure to you? And they say, yes. And I say, great. Will you sign the consent? And they say, yes. If they say, no, I don't understand the procedure, y'all do not get the consent signed and do not explain the procedure to them. That is not legally our responsibility. It is the surgeon's responsibility to get to explain the procedure. So I have to notify the surgeon of the client's express lack of understanding. Do not get the consent signed if they say they don't understand it. Okay. All right. Next question. During pre-admission testing for same-day surgery, okay, so they're coming in and they're going to have surgery that same day. So pre-admission testing, a client states that she has added garlic each day to her diet to help control her blood pressure. What should the nurse ask the client next? What type of surgery are you having? What is your normal blood pressure? Which type of anesthesia are you having? How much garlic are you eating? Okay, so they come in. She says, I've been increasing the amount of garlic in my diet to control my blood pressure. What do I do next? So I would do I expect the patient to tell me what type of surgery they're having? No, I don't expect them to tell me that. I should know what type of surgery they're having, so I'm not gonna ask them that, so I'm crossing off A. What is your normal blood pressure? I mean, I could ask them that, but that doesn't help me any. I don't know why I would ask them that. What type of anesthesia are you having? That's the same as A. C and A are essentially the same question. I don't expect them to necessarily I expect them to know A, I guess, but that's not it doesn't help with this. How much garlic are you eating? So that's the key thing. So if they say I've been having this substance, you say, well, how much of it are you having? Now, if you didn't know garlic could be a problem, garlic has natural anti-clotting um, not factors, but it has anti-clotting um, that's what it works to do. It helps to prevent clots from forming. And so, like I work in public health. Every once in a while, I go over to Malawi, which is in East Africa, and I do public health there. And we do see people who've had strokes, and we tell them to increase the garlic in their diet because aspirin isn't necessarily available to people in the village. So we talk with them about garlic as something that they can increase in their diet. So that's part of the reason I know about garlic. But garlic is good to take if you are at risk for clotting. Why they're taking it for their blood pressure could have some antihypertensive effects, I suppose. So I need to know how much they're taking because if they're going into surgery, I need to know how much they're taking. Then, so that's what you do next. Then what I would do is once I find out how much they're taking, I would notify the surgeon about that and probably the anesthesiologist as well. Then because they would have to decide if they were gonna do the surgery with whatever amount of garlic that they're taking in. All right, 4, prior to surgery, the client is to take nothing by mouth after 0400, which statement indicates the client did not follow preoperative directions. All right, so they can't have anything to eat after 0400. So which one is not following? Ate a gelatin dessert at 0300. Okay, 0300 is before 0400, so they are following directions if they had gelatin at 0300. Brushed their teeth at 0400 but did not swallow. Okay, so that nothing by mouth means don't swallow or ingest anything. You can brush your teeth as long as you don't swallow it. As long as you're just rinsing your mouth out and you don't swallow it. So that's okay. Held a cold washcloth against their lips. They didn't ingest anything. They didn't swallow anything. So that's okay. Smoked a cigarette at 0600. So 0600 is after 0400. And smoking a cigarette is ingesting something into their body. So I'm going to have to pick that one. So when they say, like, don't eat or drink anything after whatever time, that includes don't smoke. You're not allowed to take anything in except what they've prescribed. Like if they say don't eat or drink anything after 0400, but take your antibiotic at such and such a time. All right, then you can take the antibiotic at such and such a time. But if they just say strict NPO after such and such a time, that includes smoking, y'all. They're not allowed to smoke. And that's because the nicotine will affect respiratory, it'll affect blood pressure and all kinds of stuff. So, all right, 5. The surgeon prescribes cefazolin, which is an antibiotic, 1 gram to be given IV at 0730 when the client's surgery is scheduled at 0800. What is the primary reason to start the antibiotic exactly at 0730? So this is actually a frequently written order where they want the pre-surgery antibiotic given at a specific time. And usually when we're told to give medication, like say they schedule a medication at 0900, we know there's like an hour window on either side of that, right? We can get anywhere between 8 and 10. But a pre-op antibiotic cannot be given at any time. It's given at the exact time. And they're asking you, do you know why that is? Legally, the medication has to be given at the prescribed time. Now, that's false. Legally, it does not have to be. The antibiotic is most effective in preventing infection if it is given 30 to 60 minutes before the operative incision is made. That is true. C, the postoperative dose of cefazolin needs to be started exactly 8 hours after the pre-op dose of cefazolin. That's false. D, the peak and trough levels are needed for antibiotic therapy. No, that's not true. We don't do peak and trough levels for cefazolin. All right. So the only one that's true is B. So I put this one on here really just to teach you why this is, because you could see it. You could see this on the Nclex, and you could even see it in real life. And so you need to realize that a pre-surgical antibiotic has to be given at a specific time. And if you're on the floor working, you're like, how can I make sure it's given just a half hour before surgery? You on the floor don't give it. You send it down to surgery with them, and they give it downstairs in pre-op holding, because they know exactly when the surgery is going to be able to be started. So they typically send the antibiotic to the floor, but then you send it down with the patient to pre-op holding when they go to OR, so they can hang it at the exact right time. 6, on the day of surgery, a client with diabetes who takes insulin on a sliding scale is to have nothing by mouth and all medications withheld. The client's O600 glucose level is 300, which is pretty high. What should the nurse do? Withhold all medications, administer the insulin dose dictated by the sliding scale, call the healthcare provider for specific prescriptions based on the glucose level, or notify the surgery department. So you don't need to notify the surgery department. And I would not administer it based on the sliding scale, because we are given an order to be NPO. So I'm going to have to call the healthcare provider to see what I would do about this. And again, these are common fundamental principles related to pre-op that we're going over. It's not very interesting for me to like lecture on it, but for me to teach it to you by going through these questions, I think is an appropriate way to do that. So if you're given an order for them to be NPO preoperatively, but their blood glucose is high, don't just go, oh, well, they're NPO, I guess I'm not going to give them anything. No, you have to call and get an order, because they're under stress. Surgery is a stress on the body. Besides the fact that they feel stressed, surgery is an actual stress on the body and causes the release of cortisol and other things, which increases blood sugar. So they are going to need to get some insulin. Okay. I don't know what the surgeon is going to want to order, or the healthcare provider may want to order it, but they are going to need to get some insulin for this. A client will receive midazolam hydrochloride during surgery. Which finding indicates a therapeutic effect? Amnesia, nausea, mild agitation, and blurred vision. Well, just from it, just using my common sense, I would not want mild amnesia during surgery. I certainly don't want nausea during surgery, and they're going to be asleep. So why do I care about blurred vision? So the only one that makes sense here is amnesia. However, and that is the correct answer, but let me just make sure you know this. So the Pamalams, they end in Pam or Lam, like lorazepam, midazolam, right? Pam and Lam, they end in Pam and Lam. They're benzos, benzodiazepines, which is a downer. Okay. So like opioids are downers. Alcohol is a downer. Percocet is a downer. Benzos are a downer. Fentanyl is a downer, right? All these drugs are downers. And so they are often given during surgery. And one of the things that this particular one causes is amnesia, because you don't want them to remember, obviously, what's going on. You don't want to wake up and go, I can remember when you cut into my abdomen. That's not what we want. Even though you hear horror stories like that, y'all. Like you hear horror stories about people who wake up during surgery. Oh, I can't even imagine. Okay, 8. When the nurse administers IV midazolam, the client demonstrates signs of an overdose. What should the nurse do next? So in the last question, I told you midazolam is a downer. So when you give a downer, you should expect down symptoms like decreased respiratory rate, decreased heart rate, decreased level of consciousness, decreased reflexes, decreased peristalsis, right? Everything goes down when you give a downer. So if I have signs of an overdose, I'm worried they're going to stop breathing or their heart's going to stop. So when I look at this, let's look at this, see what the answers are. Ventilate with an oxygenated bag valve mask, prepare ECG paddles in case the client has a cardiac arrest, administer 0.5 mil epinephrine, titrate flumazenil to reverse the effects of the midazolam. Okay, what should the nurse do next? So any of those seem okay to do. So the question is, which one do I do next? So I am not going to administer 0.5 mils of epinephrine next. I'm not going to titrate the flumazenil to reverse the effects next, although flumazenil is the reversal agent. What I'm concerned about is that they either have decreased their respiratory rate or stopped breathing, or their heart has stopped. Now, the fact that B says prepare ECG paddles in case the client has a cardiac arrest, like I like B, but I also like A. So if they had an overdose, think about fentanyl overdose, right? What does Narcan do? When we Narcan them, they start breathing and the heart starts up again. So is it more important that I oxygenate them next or prepare the paddles? Because it doesn't say they've had a cardiac arrest yet. So it doesn't say their heart has stopped. So is it more important that I ventilate them or that I prepare the paddles? So the correct answer is to ventilate them. And the way I get this answer for me is I use ABCs. I don't use ABCs for everything, but in this kind of a situation where I have one patient and it's sort of an emergency situation, with one patient in an emergency situation, I go, well, ABCs, I'm going to pick the AB over the C to start out with. If it's a next question, okay, or first question, what would you do first? What would you do next? So I'm going to ventilate them. And don't say, how do you know they're not breathing? They could be breathing, but if I suspect they're having an overdose, they're probably under ventilating. So they may be breathing at like 3 or 4 breaths a minute, but I'm still going to have to ventilate them because that's not adequate. 9, metoclopramide is prescribed as a pre-medication for a client about to undergo a gastroduodenoscopy. What is expected therapeutic effect of this drug should the nurse assess in this client? What expected therapeutic effect of this drug should the nurse assess in this client? So I don't love this question because it's hard. We don't really assess a therapeutic effect with metoclopramide. So metoclopramide is Reglan. I don't know if you've ever heard of it. We can give it IV. We can give it PO. Probably in this case, we would have given it IV push. So you really can't assess this because there's no way to really assess it. But if we want to decrease the risk of gastric acid reflux, because if you're doing a gastroduodenoscopy, you're increasing the risk of gastric reflux. I can give like a PPI, proton pump inhibitor, which is Protonix, for example, or I can give an H2 receptor blocker. An example of that would be ranitidine. I think that might be Zantac. Those decrease the amount of gastric acid in the stomach. Or I can give metoclopramide, and I don't remember the class of drug that it is, but what I know it does is it increases gastric emptying. So it doesn't decrease the amount of acid in the stomach. It actually decreases or increases gastric emptying. So metoclopramide increased gastric emptying, but you can't really, that's why I say I don't like how the question is worded. You can't really assess that so much, but we definitely don't want to increase gastric pH. And there's no reason that it would reduce anxiety or inhibit respiratory secretions. So anyway, it increases gastric emptying if you don't know what metoclopramide. I mean, if you don't know what it means, maybe you would have guessed C or D, but I'm just telling you what metoclopramide does, Reglan. All right, 10. During the pre-op interview, the nurse obtains information about the client's med history, which information is not necessary to record about the client. Current use of medications, herbs, and vitamins, that is important. We need to record that. Over-the-counter meds used in the last 6 weeks, maybe. Steroid use in the last year, absolutely, and I'll explain that to you at the end. All drugs taken in the last 18 months, maybe. So I know we have to record current use of meds, and I know we have to record steroids used in the last year. So we want to know which ones are not necessary. So is it not necessary to record over-the-counter meds used in the last 6 weeks or all drugs taken in the last 18 months? So 18 months seems pretty far out. I don't see why I would need to document all drugs taken in the last 18 months. In fact, I don't even know if they could remember them. So it's more likely that I would not need to record all drugs taken in the last 18 months. And don't forget, this is what is not necessary to record. Not asking what is necessary to record, because you do have to do A, B, and C. Now, steroid use, what happens with steroid use is when you take steroids, it actually reduces secretion by the adrenal gland of stress hormones. So stress hormones like cortisol, glucocorticoid, mineralocorticoid. When you give people those medications, the adrenals reduce how much they secrete, which means when you stop taking them, you stop taking steroids, it takes a while for the adrenals to start to secrete those again. Sometimes, depending on how long you've taken steroids, it can take a long time for the adrenals to start to secrete those again. And they're going in for surgery, y'all. And that is a stressful event. And if they go in for surgery and they don't have adequate stress hormones, they're going to be in big trouble. Okay. So you have to know what the steroid use has been in the last year, because for some people, even if they've reduced the amount of steroids over maybe they were taking like a high dose and then they were kind of starting to wean off of it, they may need to go back up to a higher dose until they've recovered from surgery, because their body's not going to make enough. So it is really, really important, whether I'm talking clinically, if it's on the Nclex, it's true as well. But I'm telling you, in real life, y'all, you got to make sure that you know before your patient goes for surgery what kind of steroid use they might have. You can have a really serious complications if you don't figure that out. All right, I think this might be the last one. I'm not sure. The nurse teaches a client who had a cystoscopy, which is a scope of the bladder, about the urge to void when the procedure is over. So I'm teaching them that once you have this, it may really feel like you have to urinate again. What other information should the nurse tell the client to expect to do? So I'm going to say, okay, you're going to feel like you have to go to the bathroom. That's normal. Just go, and eventually that will pass. All right, ignore the urge to void. Well, no, I never tell anybody to ignore the urge to void. Increase intake of fluids. That sounds like a good idea. Ask for a bedpan. I don't know why I would tell them to ask for a bedpan. A cystoscopy is just a scope of the bladder. They're not given general anesthesia or anything. So I don't see why I would tell them to ask for the bedpan. Ring for assistance to go to the bathroom. Maybe. So let's say they just had a cystoscopy. I can't even say it. I'm going to tell them they're going to have an urge to void. And I'm either going to tell them increase intake of fluids or ring for assistance to go to the bathroom. Now, if I want to decrease their risk of developing a post-procedure infection, one of the things I'm going to want it to do is increase the intake of fluids. And they didn't tell me they were at risk for falling. There's nothing here. It's a very vague question. They don't tell me anything about the client. All they tell me is about the procedure. So I cannot I cannot pick an answer that I would have to know more about the patient to answer. I can only make a decision based on the procedure, because I don't know anything about the client. So based on what I know about the procedure, I know they're going to have an increased risk to void, and I know it would be a good idea to increase fluid. So I'm going to have to pick that answer. This is very common to get on the Nclex. You're going to get questions on the Nclex that are very vague. They just may say a client who had this procedure, and you can only answer questions based on what you know about the procedure itself, not about the client. Because if all they say is a client, they don't tell you the age, they don't tell you any diagnoses, they don't tell you any comorbidities, they don't tell you anything, then that means you're only answering questions about the procedure itself. Okay. All right. Well, that's it, y'all. Quick one there today. So maybe not so quick. So I hope you have a great rest of your day, and I will talk to you later.